What are the components of the blood gas? This is some of the components. pH is usually 7.35 to 7.45, PCO2 35 to 45 mercury millimeter, and PaO2 80 to 100, and bicarbonate is normal value is 20 to 24. This all you can understand. And base excess, which is -2 to +2. I'll explain what is basic. And apart from that, metabolic panel, like some blood gases give the sodium, potassium, chloride, and calcium as depicted in the right side of your slide here. And hemoglobin, lactate, and blood sugar. So these are the basic things which elaborate in the blood gas report. What is base excess? Other things I think it's all self-explanatory, but what is the base excess? Okay, so understand what is base excess. Normal base excess value is -2 to +2. Okay, if the base excess is below minus, that is more towards the metabolic acidosis. Base excess is something for you to tell about the metabolic component, whether the patient is acidosis in acidotic. If it is a base excess is below minus, so that is if it is more minus, like -5, -8, or -10, that is more acidic. If a base excess is more positive, it is metabolic alkalosis. Say positive +3, +4, it is more alkalosis. So if the base excess is minus, it is metabolic component, metabolic acidosis, more metabolic acidosis. So it is the base excess is defined as the amount of acid that would be added to blood to titrate it to pH 7.4 at PCO2 is 40 mercury millimeter. So it is defined how much of acid should add to this patient to take your blood to the level of pH 7.4. Okay. So if the base excess is more negative, it is acidic. If the base excess is more positive, it is alkaline. If you can remember that too, that is enough, because you are not going to define the patient with the blood gas. So just make these last two sentences. If it is more negative, it is acidic, and more positive, it is alkalosis. That is enough. I try to make this very simple, and we'll build up from there. Okay, right. Take this primary acid-base disorder. Sorry. pH PCO2 bicarbonate. Normal range, look at the third column, is a normal range 7.35 to 7.45. PCO2 normal range between 35 to 45, and bicarbonate is 22 to 26. Right. It's the primary disorder. If the normal range is less than 7.35, it is acidemic. And if it is more than 7.45, it is alkaline. That is obvious. That is, Then, if the carbon dioxide level is less than 35, it is the respiratory alkalosis. If the carbon dioxide is more than 45, it is respiratory acidosis. And if then the bicarbonate panel. If the bicarbonate is less than 22, it says it's a metabolic acidosis. And if it's more than 26, it is metabolic alkalosis. So this is so simple. Okay. We'll start from basic. It's a simple thing. You can understand. Right. There are 5 steps of blood gas analysis. From here, you have to take a piece of paper and write this first formula. If carbon dioxide diluted by water, it may the carbonic acid H2CO3, and then it dissociates to bicarbonate and hydrogen. Please write this on in a piece of paper, and this will need for further later on for the blood gas analysis. I'll give you some analysis. We'll do some analysis with this lecture. So this is important formula for us to go for further discussion. Right. First step, once you get the blood gas, first step is to decide whether you are dealing with acidemia or alkalemia. If the patient pH is less than 7.35, yes, acidemia, more than 7.35, more than 7.45, alkalemia. Right, that is the first step. So you pass the first step. Good. Are you okay? Are you all sleeping or okay?
Yes.
Okay,
Yes,
sir.
Okay, sir.
Then
Okay.
Okay, sir.
step 2. Step 2. Now we have to find the cause for this acidemia and alkalemia. Whether it is the primary cause is a respiratory or metabolic. Just look at your carbon dioxide and bicarbonate. Okay. If there is the hypercarbia, yes, we are dealing with respiratory acidosis. If you have hypocarbia, yes, we are dealing with the respiratory alkalosis, right? And then take the bicarbonate. High bicarbonate, yes, obviously metabolic alkalosis. Low bicarbonate, metabolic acidosis. Right. Now tell me, one of you guys, pH is 7.30. Okay. So first step, what is this? It is acidemia. Acidemia. Right. So now you have to find what causes this acidemia following these four. Could it be due to low partial pressure of carbon dioxide?
No.
No.
No, no.
Okay. So can it be due to high carbon dioxide level?
Yes.
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 So
Yes.
this pH is, so you have to look at the pH and then the carbon dioxide level here. The contributing factor for this pH is increased PCO2. Good. So we are not determined it is a respiratory or bicarbonate. Then you go to the bicarbonate. Can this be pH is due to low bicarbonate?
Yes.
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 Can it be due to high bicarbonate? Can't.
No.
No.
Then the third one, this will be tricky. So this pH is 7.30. Can it be increased PCO2 with increased bicarbonate?
Can.
Yes. Can.
Because according to the
PCO2 is
formula,
very high.
according to the formula which I have given before, this could be the primary problem is, so this increased bicarbonate should not be the primary cause for this pH, but it is the secondary cause. The primary problem is increased PCO2. So increased carbon dioxide diluted in the increased carbon dioxide dilution in the water gives the bicarbonate and hydrogen. So that is why this patient has high bicarbonate. So the primary pathology here is increased PCO2. So this patient is having a primary respiratory acidosis. Though there is a high bicarbonate, we can't call it alkalosis. So this is the primary problem is PCO increased PCO. So can this be due to low bicarbonate and low PCO2?
Yes.
That's also possible because low bicarbonate is with the pH acidosis. So it could be a metabolic acidosis, but because of the metabolic acidosis, take that formula or the equation. When there's a low bicarbonate on your right side, then the carbon dioxide also low. So this could be a metabolic acidosis with the primary problem is metabolic acidosis with the low carbon dioxide. Low carbon dioxide is the compensatory process. Now you know 3 steps. Right. Steps of blood gas, the third step. Is there a, now you know how to analyze the primary problem is the metabolic acidosis or metabolic alkalosis, respiratory acidosis or respiratory alkalosis. Now the third step. This is the this is bit of difficult, not difficult, you can understand. Is there additional compensation for the primary disorder? That is what we want to look at. There is a respiratory, usually there's a respiratory compensation for a primary metabolic process. But this compensation is very rapid. Okay, it can be minutes and hours. There's a respiratory compensation for a primary metabolic process. And there is a metabolic compensation mainly by renal for respiratory process. But this compensation is very slow process. Usually take 3 to 5 days. From minutes to 3 to 5 days. So the metabolic compensation is slow, respiratory compensation is rapid. That is obvious, self-explanatory. Right. Now, get the step 3 metabolic acidosis. Some of you guys know what is this is, but I assume from the basic medical officer what you should do. So So this formula is called what is called Winter's formula. So we have to need to check, you have to make it a snapshot or write it down, need to check whether the respiratory compensation is adequate or not. In a patient with a metabolic acidosis, you have to check whether the respiratory compensation is adequate or not. So we have to predict the patient PCO2 by applying this formula, this equation. Okay. If the patient carbon dioxide and the expected carbon dioxide is the same, expected mean by derivate from, we are getting the assumed by carbon dioxide from this formula, this equation, and expected carbon dioxide is, if it is same, we can say adequately compensation has been established by the body. Is it okay? Good. Are you okay? I can't hear.
Yes,
Yes.
sir.
Oh, good.
Yes, sir.
If the patient carbon dioxide is higher than the expected value which is taken from this equation, if it is a PCO2 is higher than the expected, there should be a respiratory acidosis is present in addition to the primary metabolic acidosis. That was not fully compensated. So there has been a respiratory component in addition to the primary metabolic acidosis. If there's a patient carbon dioxide is more or less than the expected, then there is a respiratory alkalosis in addition to the primary metabolic acidosis. This equation is very important. Keep it in mind. Right, this is the second equation. Write in the in the piece of paper, because we have to do a lot of calculation today. Right. So far, so good. I think good. Then, so what about the metabolic alkalosis? I told you, with the first equation, the respiratory system compensates for a metabolic alkalosis by increasing the carbon dioxide level. When there's a metabolic acidosis, the more bicarbonate is there, the equation, the formula shifted to the left side and produce more carbon dioxide. But unlike a metabolic acidosis, in a metabolic acidosis, they compensate by hyperventilating. They try to wash out the carbon dioxide by doing hyperventilation. But unlike the metabolic acidosis, the normal respiratory compensation to the metabolic alkalosis is difficult. We can't difficult to predict it, because respiration, what the body does is they increase the metabolic alkalosis by increasing the PCO2 level. They compensate the metabolic acid alkalosis by increasing the PCO2 level in the body. How? It does the hypoventilation. Hypoventilation causes retention of carbon dioxide, and this carbon dioxide causes acidosis. So, but PCO2 level rarely rises above 50 mercury milliliters with this measure. The reason is, when the patient is keep on hyperventilating, it causes the hypoxia as well as hypercarbia, which triggers the respiratory center and causes rebound hyperventilation. So in practical situation, this rarely rises about 50, right? But we have to predict the carbon dioxide level. That is the prediction, and we have to compare with the actual carbon dioxide with the blood gas panel. The third equation is PCO2 is equal 0.7 into bicarbonate plus 20 with 2 standard deviation. So this is the third formula I'm giving. So we can predict with the alkalotic patient with the metabolic alkalosis, we can predict the assume carbon dioxide level if the body works according to our formula. We don't know whether the body is working according to our formula. We'll see what happens. Right. Then again, still we are in the step 3, the respiratory acidosis versus alkalosis. Renal compensation for respiratory acid-base abnormalities improves with the time. In acute changes, within 48 to 72 hours, in the chronic situation is more than 72 hours. Right. Now, fourth formula, this is not equation, so fourth theory. every increase in PCO2 in respiratory acidosis, every increase in PCO2 of in 10 mercury millimeter, this causes bicarbonate increase by 1 millimole in acute setting and 4 millimole in chronic setting. Okay, if you go back to the equation, carbon dioxide diluted the water causes bicarbonate and hydrogen ion. When there is a more carbon dioxide, it produces the bicarbonate. It shifts the equation to the right side and produce the bicarbonate. With this respiratory acidosis, if it is acute condition with the 10 millimole of carbon dioxide, they produce 1 millimole of, it produces 1 millimole of bicarbonate in acute setting. But in the chronic respiratory acidosis, like COPD patient, it produces 4 millimole of bicarbonate. This theory, you have to keep it in your mind. You have to cut apart with this two, third, this is fourth formula. And step 3 again, the respiratory alkalosis. What happened with the respiratory alkalosis? Carbon dioxide goes down because of the hyperventilation due to many reasons. Every decrease in PCO2 of 10 millimole, bicarbonate level decreased by 2 millimole in acute setting and 5 millimole in chronic setting. Okay, this is the fifth formula. So there are 5 formulas. Okay, so these formulas will give a rough estimation of respiratory acid-base disorder is being compensated by the kidney, and whether we have to find whether the patient is suffering from an acute or chronic or otherwise acute or chronic respiratory ailment. So these formulas are important, right? Again, a summary, not the last summary. So carbon dioxide dissolving by water and making the hydroxylamide, making the bicarbonate and H+. First step, we have to look for whether the acidemia. Step 2, whether it's a primary or metabolic causes. Primary, we have to find the primary causes. Okay. Third step, there are 5 things. 4 things, is there appropriate compensation for this primary disorder? If this metabolic acidosis, yes, PCO2 is equal 1.5 to serum bicarbonate plus 8, which is called Winter's formula. And metabolic, if it is a metabolic alkalosis, PCO2 is equal 0.7 into bicarbonate plus 20 plus or minus 2. And everything in formulas plus or minus 2 is applied. And the respiratory acidosis, increase carbon dioxide in 10, which increases the bicarbonate by 1 in acute and 4 in chronic, 1 and 4. And respiratory alkalosis, PCO2 increased by 10 leads to PCO2 reduced by 10 leads to reduction in bicarbonate by 2 in acute and 5 in chronic. So 1, 4 in respiratory acidosis, alkalosis 2, 5, 14 and 25. Get a snapshot of this one and keep this one in your phone when you analyze the blood gas, even in a practical situation. All right. Now we will interpret this blood gas. A 70-year-old smoker present with an acute onset of shortness of breath. We'll go with the simple. pH 7.30, PCO2 60, PO2 60, and metabolic panel sodium 135, chloride 100, bicarbonate 30. So now I have given you, so this is the patient coming with the shortness of breath. So I have given you now 3 steps. Can somebody analyze this one quickly? It's a very simple. Analyze this one quickly and tell me what is the problem. Is this adequately compensated or not? Is okay or what? Okay, so primary problem?
Respiratory acidosis.
Respiratory acidosis. Then what you have to look for? Whether it's adequately compensated or not?
So this is a respiratory acidosis partially compensated by metabolic CO2 bicarbonate.
Partially, this is respiratory acidosis, partially compensated.
Compensated.
Yes. Yeah. Step 1, acidosis. Step 2, respiratory. Yes, respiratory acidosis. PCO2 increased by 20. So therefore, the bicarbonate should increase by 2 if acute and 8 if chronic. We don't know if it's acute or chronic, but the history is important. History says the smoke. Okay, because the bicarbonate increased from 24 to 36, And this patient bicarbonate level is, what is the bicarbonate level in calculation?
30.
30. Is 30?
Yes.
5.
Yes. Okay, so this is the patient is a chronic respiratory acidosis which is compensated by bicarbonate. Okay, I just gave this example to work out these 3 steps, right? We'll move to another one. Again, a 32-year-old man with depression and alcohol abuse, present with the altered mental state. ABG, pH 6.9, PCO2 29, PO2 100, metabolic panel sodium 140, chloride 101, bicarbonate 5 millimole, not 5 millimole. Can somebody tell me what is happening there?
Metabolic acidosis with partial compensation.
Yes, good. Step 1, yes, it's a metabolic acidosis. Step 3, PCO2 1.5 into serum bicarbonate plus 8. 1.5 bicarbonate is 5, plus 8, 7.5 is altogether around 14, around 15. But the patient's carbon dioxide is higher than the 15. What's the patient carbon dioxide? It is 29. Okay, but the calculated carbon dioxide 15. So what is the problem here? So therefore, apart from the metabolic acidosis, this patient has respiratory acidosis as well, possibly due to secondary to CNS depression due to alcohol ingestion. Okay, all right. So this patient has taken, this patient has a very good patient. He has taken alcohol up to the level of developing acidosis. Acidosis in a coma patient. So now we have discussed with 3 steps and with the 2 examples. This fourth step, which is a bit of not difficult. These all are simple. Steps in blood gas. Step 4. Now, when there's a metabolic acidosis, there's another entity called anion gap. I'll tell you why we develop anion gap. Anion gap is calculated. Sodium, sum of bicarbonate and chloride is subtracting from the sodium, which gives the anion gap. If this anion gap is more than 12, we call anion gap metabolic acidosis is present. Is there a gap in anion gap in our body? Can we have a gap? Yes, we can, in not actual situation, but with the calculation we have. I'll tell you. So anion gap is unmeasured, and we don't measure all the anion. So unmeasured anion is the normal. Normal anion in the calculation, it's around 10 to 12. They are negatively charged proteins like albumin and phosphate or sulfate, some organic anions or citrates. How this can happen? Okay, so you can appreciate there's a sodium, the extreme left side, and the middle, the normal person, there's a normal anion gap, which is one we have not measured, like citrate and phosphate and sulfate and all. And then the bicarbonate level is there, and then the carbon dioxide. Chloride. So this is the normal, but normally we have an anion gap. This is 10 to 12. When it moves to the extreme right side, there's a metabolic acidosis with anion gap. Normal anion gap is there. It's a normal anion is there. And chloride is also there, sodium is normal. But in addition to that, at the expense of bicarbonate, there's excess anion here. This is what we are going to measure with the anion gap. We have to measure this anion gap to see what causes metabolic acidosis. Some of these anion might have caused metabolic acidosis. That is what we are going to look for. That is called anion gap. So we have a high anion gap. So that is unmeasured. We have unmeasured anion in our body, but there are increased unmeasured anion. They are lactic acid due to hypoxia and shock, and phosphate and sulfate probably renal failure, and ketoacidosis could be diabetic ketoacidosis or alcoholic ketoacidosis, and oxalic acid like ethylene glycol poisoning and formic acid in methanol poisoning. So this is a high anion gap. How does the acidity develop in our body? We have acidity 7.4. So how do we develop acidity? One thing, adding acids. Some make like lactic acid, sulfate, or keto acids. Adding acid causes acidity. That is one way of developing acidity in the body. What is the other way? Removing bicarbonate from the body. That also causes acidity. Either adding acid or removing bicarbonate. Both entity can lead to acidosis. Right. Now, the step 5. This is the step 5 is useful to detect the previously undetected metabolic disorder. Okay. So far is so good. Can you understand? Have I confused you or totally understand? Can somebody respond?
Yes, sir.
Okay, good. So these the useful to detect now previously undetected metabolic disorder. So as I shown you previous picture here, right, when the excess anion gap is increasing, the bicarbonate is coming down. Bicarbonate is low. It's getting low. Right. The theory here, every increase in the positive charges, so there must be an equal decrease in negative charges. A patient with an anion gap metabolic acidosis, the elevation of the anion gap over 12 should be accompanied by a similar decrease in the bicarbonate concentration from the normal level. Every increase in anion gap should decrease the similar decrease in the bicarbonate. As is shown here, as you can see, every increase in anion gap, the bicarbonate level goes down from 24. So if the bicarbonate is lower than the expected level, then the additional metabolic acidosis of the non-anion gap varieties exist, or respiratory alkalosis is present. If this expected bicarbonate is lower than the expected patient actual bicarbonate is lower than the expected bicarbonate, yes, then the metabolic acidosis, in addition to the metabolic acidosis from the primary metabolic acidosis, there is the additional non-anion gap metabolic acidosis. If the bicarbonate concentration is more than accepted, then the metabolic alkalosis is present. Okay, this calculation is called the delta gap. This calculation is called the delta gap. We'll see how the delta gap works. Okay, delta gap or delta ratio. Now you know what is anion gap. This shows the delta ratio is delta anion gap divided by delta bicarbonate. That is, this is I think the 6th formula. Anion gap minus 12 divided by 24 minus bicarbonate level. And with this, you can get some value. Okay, there should be a value. Right. If this value is less than 0.4, if this value less than 0.4, it shows the hyperchloremic non-anion gap metabolic acidosis. I'll teach you later what are non-anion gap metabolic acidosis, what are anion gap metabolic acidosis. Don't worry about that. So take it as if it is less than 0.4, it is a non-anion gap metabolic acidosis. If it's between this value between 0.4 to 0.8, this is mixed picture with high anion gap metabolic acidosis plus non-anion gap metabolic acidosis. There are two things happening together. Right? If this value is between 1 to 2 or 0.8 to 2, it is called pure high anion gap metabolic acidosis. Pure high anion gap metabolic acidosis. And if it is more than 2, take a snapshot and see it's more than 2, it is metabolic acidosis with pre-existing elevated bicarbonate level. Could be patient is having a metabolic acidosis with pre-existing metabolic alkalosis or respiratory acidosis. This is a bit confused. How do you get metabolic acidosis on top of the metabolic alkalosis? We will work out later. So if it is more than 2, patient's primary problem is metabolic acidosis, but in addition to that, there's a pre-existing elevated bicarbonate, either due to metabolic alkalosis or due to respiratory acidosis, because respiratory acidosis also increases bicarbonate. All right, are you confused?
No, sir.
Okay, good. Right. Any question? No. Interpretation of the blood gas now. The clinical picture should be considered after acid-base condition has been made. So the patient history and examination is paramount in this interpreting the blood gas. The result of acid-base determination cannot be properly interpreted without clinical correlation. There should be some clinical correlation for you to understand. So these are very basic. There are a lot of shortcuts, but first we'll learn this basics thing, and one of the another lecture, another day, I'll teach you the rest of the thing. Okay. When you talk about the metabolic acidosis, there are two types of metabolic acidosis: high anion gap metabolic acidosis, which is more than 10 to 12, and non-anion gap metabolic acidosis, which is less than 12 or less than 10. So, but one potential pitfall in the measurement of this anion gap is with low albumin, because for each 1 gram drop in serum albumin level, the anion gap decreased by 2.5. Every 2 gram drop in serum albumin causes the anion gap decrease by 2.5. So if you have if a patient has a low albumin level with the anion gap, they measure the lower value than the proper patient anion gap. So what is the patient with a calculated anion gap of 10 and a 2 gram drop in their albumin? What would be the patient actual anion gap? If a patient with a calculated anion gap of 10, sorry?
5.
5. What is the anion gap? Calculated anion gap of 10, but the patient 2 gram drop in the albumin.
15.
15. So yeah, so it should be 15. You are correct. I'm sorry.
15.
So it is 15. Okay, try to analyze this albumin as well when you're in a critical situation, when you analyze the blood gas, especially in people who are sitting for postgraduate exam part 1. Right, these are not a bit rocket science. This is simple mathematics. Right, what are the causes for high anion gap metabolic? Is called a cat mud pile. You know all this. A cat. Analgesics, the massive NSAIDs and acetaminophen, cyanide, carbon monoxide, poisoning, arsenic, toluene, methanol and metformin, uremia, diabetic ketoacidosis, paraldehyde, penformin, iron or isoniazid, lactic acid, ethylene glycol, or salicylate. It's very large list, but you can make, if you can, I couldn't write this one, a simple mnemonic for CULT, K-U-L-T. The simple mnemonic for you to work out high anion gap metabolic acidosis, CULT, K-U-L-T. K mean ketoacidosis, either to diabetic or alcoholic. U mean uremia or renal failure. L mean lactic acidosis, and T mean toxins. Another simple mnemonic, K-U-L-T. Sorry, I couldn't enter that one here. K-U-L-T, CULT. So this is the causes for HAGMA. So if you have a patient with high anion, you get the patient metabolic component primary problem, you sort it out. Then you get the step 3, and you found that the patient is having high anion gap metabolic acidosis. Now you have to find the cause for this one. We will give the patient diagnosis or close to the diagnosis by with the blood gas or differential diagnosis. Another thing, in the metabolic acidosis, now you anion gap and delta gap. This is another entity, it's a small entity, it's not a big one. Osmolar gap. There's a difference between the measured osmolality of the blood and the calculated osmolality. We can calculate the osmolality. See, osmolar gap is the osmolality, measured osmolality minus calculated osmolality. How do we calculate the osmolality? with your blood sample. So 2 sodium plus glucose plus urea. All of these are in millimoles. So by this mean, you can calculate normal value of osmolality. Normal osmolality. So normal value of the osmolality is less than 10. It is there. It should be there. I mean, normal. There are some osmotically active particles which we don't measure. So what we calculate osmolality, we have given that non-calculated osmolality number is 10. So we can get the calculated osmolality by 2 sodium, glucose, and urea. If there is a difference, then there is a osmolar gap. What makes the osmolar gap? Yes, osmolar gap. If osmolar gap is very high, the presence of unmeasured osmotically active substances should be considered. It could be ethanol or methanol, lactate or isopropyl alcohol, ethylene glycol, all these are unmeasured osmolar gap. Ethylene glycol is engine oil. Lactate, you know. Ethanol is one of your friends, ethanol. Some guys, this friend is ethanol. So they make the osmolar gap or they make the acidosis as well themselves. Good. Now we'll move to another example, right? 32-year-old man with depression and alcohol abuse, present with altered mental state. Now I have given you so many steps now. pH 6.9, PCO2 29, VO2 100, and sodium 140, chloride 101, bicarbonate 5. Now can somebody analyze this blood gas and tell me detailed history of this one, detailed blood gas analysis. I have given you several steps. It's a simple calculation from step 1 to step 5. Somebody? Anoma. Yes, Anoma. Here. Who is going to talk?
This is metabolic acidosis
Yes.
with increased anion gap.
With high anion gap.
High anion gap.
Right. Yes. How about the compensation? Carbon dioxide compensation? Respiratory compensation?
Partially compensated.
Partially compensated. Good. Acidosis, metabolic, step 3, carbon dioxide, which is given previously. But this example is given previously. Bicarbonate was 15. There's a respiratory acidosis is present, possibly secondary to the CNS depression. Anion gap is 34. Anion gap is 34. So the delta gap. Measure the delta gap. 34 minus 12 divided by 24 minus 5. It is 1.05. It means no additional metabolic disorder. If it is 1 to 2, that causes the pure high anion gap metabolic acidosis. Anything else you want to know? Which I have not given. Anything else you want to know? Anything else you want to know with this panel? What else you want to know? So the high anion gap metabolic acidosis with partially compensated with respiration. What else you know?
Patient serum albumin levels.
Serum albumin level, yes, excellent. We need to know the patient serum albumin level. Very good. Another one.
Blood glucose level.
Blood glucose level. Apart from that, some other simple thing. which I have told. No, we need to know the
It's an alcoholic for the methanol level.
Yeah, or this patient need the osmolar gap. Osmolar gap. This patient osmolar gap, we have not measured here, there's no adequate data. We measured the osmolar gap is 74, but finally we found that patient has a toxic alcohol ingestion with high level of blood methanol level. So this patient, so you have to analyze acidosis, the metabolic or not. If it is a metabolic acidosis, take with the Winters formula and check the anion gap and check the delta gap and check the osmolar gap, and now we are fine. Is it okay? Are you all right so far? Okay, can you all understand so far? Or are you all drowsy due to alcohol or high osmolar gap? Okay, can. Okay, right. Good. Then the non-anion gap metabolic acidosis. What is the NAGMA or non-anion gap metabolic? I told you earlier, acidosis can be due to adding acids to the body or removing bicarbonate. So non-anion gap metabolic acidosis is most of the time removing the bicarbonate from your body. GI bicarbonate loss like diarrhea, and renal tubular acidosis with bicarbonate loss, and carbonic anhydrase inhibitors, urethral diversions, that ureterocolic anastomosis and rehydration, potassium sparing diuretics, and Addison's disease. Okay, so these are the causes for non-anion gap metabolic acidosis. You will come across a patient with acidosis after vomiting or rehydration, diuretics, but then you have to find out the cause for this. So you have to diagnose this, or at least you have to do the differential diagnosis by looking at your blood gas. The case, a non-anion gap metabolic acidosis is a simple thing. A 68-year-old man who recently took antibiotics for skin infection, present with 10 episodes of watery diarrhea per day for the last 5 days. Arterial blood gas, pH 7.34 and PCO2 34, PO2 80. Metabolic panel, sodium 135, chloride 108, bicarbonate 80. Can you tell me what sort of acidosis this is? This is a simple thing. Do the calculation, though it is simple, from step 1 to step 5. Then it will retain in your mind. Even with the complicated blood gases, you can analyze. Right. So is step 1 is the acidosis is there, is metabolic acidosis. PCO2, I told the how to calculate the PCO2 in metabolic alkalosis. It's 1.5 into bicarbonate plus 8, and this is 35, and anion gap here, we measured the anion gap also 9. So this is a non-anion gap metabolic acidosis due to diarrhea with adequate respiratory compensation, because the carbon dioxide 34, measured actual carbon dioxide 34, and the measured carbon dioxide or calculated carbon dioxide 35. So this is a non-anion gap metabolic acidosis due to diarrhea with adequate respiratory compensation. Right. Then the metabolic alkalosis. Metabolic alkalosis causes due to volume contraction like vomiting, NG suction, loop diuretics or thiazide diuretics, excess glucocorticoids and mineralocorticoids, hypokalemia, Bartter syndrome, alkali ingestion, and post-hypercapnic alcohol. Those are the causes for metabolic alkalosis. You can, Google it and see the alkalosis, but what matters is not to cut apart on this one. They try to get an idea how do you get the metabolic alkalosis. So these are the causes for simple causes for metabolic acidosis. Right. Now, metabolic alkalosis a patient, the 20-year-old student present with excessive vomiting after binge drinking. Good. All are alcoholic today. because Sri Lanka is one of the country which import ethanol than any other country. So we have to be very careful about the alcoholic related problem. ABG pH 7.5, PCO2 44, PO2 100, metabolic panel 138, chloride 100, bicarbonate 34. Can you tell me what is happening here? Can somebody? This is the metabolic 20-year-old student. Yes, so difficult. Nobody's there. All are sleeping.
Metabolic alkalosis with good compensation.
Yeah. Metabolic alkalosis is good compensation. Yes, metabolic alkalosis. PCO2 points. How to calculate PCO2? This patient 0.7 into bicarbonate plus 20.
44.
44. What is the bicarbonate level? It's carbon dioxide level 44. Your carbon dioxide also 44. So this is the simple metabolic alkalosis, probably secondary to vomiting with adequate compensation. These are very simple blood gases. Okay, very simple blood gases. Right. What is respiratory? Good. Thank you, Raja. Respiratory acidosis. We move on to the respiratory acidosis. This respiratory acidosis is characterized by elevation in the PCO2 and a decrease in blood pH. The most commonly due to hypoventilation. And the condition that decreases the ability of the lungs to excrete carbon dioxide at a rate to keep up with the body's production. That means if the body production of carbon dioxide is high, like in neuroleptic malignant syndrome, hypothermia, the carbon dioxide production is high, but body is not able to excrete this carbon dioxide. In that situation also you get the respiratory acidosis, or due to hypoventilation you get the respiratory acidosis. It could be central nervous depression like sedatives, CN diseases and sleep apnea, the pleural diseases like large pneumothorax or pleural effusion, they have a hypoventilation, and lung diseases like COPD, pulmonary edema, and acute airway obstruction, laryngospasm, and neuromuscular disorders like Guillain-Barré, myasthenia gravis, and motor neuron disease, and also thoracic cage like flail chest. So all these causes the hypoventilation, which retain carbon dioxide. These are the causes. So if you have a patient with this sort of history, think that this patient have a respiratory acidosis. But the kidney compensates for primary respiratory acidosis by retaining bicarbonate. This compensation occurs over hours to days and generally maximum within 4 days. Differentiating the acute from chronic respiratory condition is very important in the clinical implication. This one, a 70-year-old smoker present with an acute onset of shortness of breath, which we have discussed before. Right? We discussed about the acidosis, the respiratory, and whether it is adequately compensated or not. Yes. So this is the step one. This is the acidosis, respiratory acidosis. And acute on chronic, we'll see how. The PCO2 increased by 20. So therefore the carbon dioxide should increase by 2 if acute and 8 if chronic. Because of the bicarbonate increment from 20. So this is an acute on chronic respiratory, which we have discussed before. So this is a simple mathematics, or simple follow just a simple step how to deal with the respiratory acidosis. So the respiratory alkalosis. This is characterized by the decrease in the PCO2 and elevation of blood pH. The causes of primary respiratory alkalosis, which include the CNS disease like CVA and the salicylate poisoning, aspirin. So this is important, toxins, salicylate poisoning, because salicylate causes the metabolic alkalosis as well as salicylate causes respiratory alkalosis because of the hyperventilation. Salicylate stimulate respiratory center. So this is called both metabolic acidosis and respiratory alkalosis. And high altitude, severe anemia, the pregnancy, And lung disease like hypoxia and asthma, especially the asthma patient comes with respiratory alkalosis, and pulmonary embolism because the patient is hyperventilated, and anxiety and fever and sepsis. They do a lot of hyperventilation, so they have respiratory alkalosis. Take this example: a 22-year-old woman present with 4 hours of numbness in both hands, typical of previous episode of anxiety. pH 7.48, PCO2 30, PO2 86. So metabolic panel 140, sodium, chloride 110, bicarbonate 22. So can somebody analyze it? This is the primary respiratory alkalosis. What about the bicarbonate? Yeah, this is the respiratory alkalosis, and it is acute. The drop in the carbon dioxide by 10 correspond to a drop in the bicarbonate by 2 if acute and 5 if chronic. So therefore, the as the expected clinical history, this patient is having bicarbonates of 22. So calculated bicarbonate is tally with the measured bicarbonate. So this patient is having a acute respiratory alkalosis. All right. Are you all okay?
Yes, sir.
Okay.
Great,
So,
sir.
right. Summary. This is my summary whole lecture. Keep this summary in your phone. But today I try to sort of give you the basic idea of blood gas interpretation. But there are many more things to discuss, like lactic acidosis, like type of lactic acidosis. There are many things for you to discuss, some complicated blood gases, and there are some shortcuts. Without having none of these without few of these formula, you can at a glance you can decide what sort of metabolic or the respiratory panel with this patient. Later on we will learn this thing. So main summary: step 1, try whether the acidemia or not, or alkalemia. Step 2, primary respiratory or metabolic disturbances. Look at the PCO2 and blood gas, ABG and bicarbonate, PCO2 and bicarbonate. And step 3, is there an appropriate compensation for primary disorder? Like metabolic acidosis, Winter's formula, PCO2, calculate the PCO2 according to this formula. If it is a metabolic alkalosis, calculate the carbon dioxide according to this 0.7 into bicarbonate plus 20. And if there's a respiratory acidosis, increase PCO2 by 10 causes increased bicarbonate by 1 in acute and 4 in chronic. If there's a respiratory alkalosis, reduce PCO2 by 10 causes reduced bicarbonate by 2 in acute or 5 in chronic. And step 4, anion gap, sodium minus bicarbonate plus chloride, anion gap, and the delta gap, anion gap minus 12 divided by 24 minus bicarbonate. And this one, delta ratio, the number of these. This is my summary. If you have these two slides, this one and this one, that is enough for you to basic blood gas analysis, and try to make almost all the blood gases, and try to do with these simple 5 steps, and try to make the diagnosis. So how beautiful the blood gas you will realize to make in the diagnosis. And thank you very much. This is my references, and this is my number and the Dominder's number. If you are finding difficulty in making the blood gases or interpreting, please Viber or WhatsApp me or Dominder. Will tell you there are a lot of things. And so thank you very much for participating, listening for the blood gases and these 3 lectures. And thank you very much, Dineshan, and thank you very much, GMOA. And stay with the GMOA. We have a series of lectures later on. not only the emergency medicine, and they will arrange a lot of other activities. And also because of this COVID situation, we can't handle, but I will teach you in how to do emergency ultrasound and how to do airway, many more things to come. We stay with GMA. Thank you very much. And if you have any burning question, I'm happy to answer, me or Duminder, one or two. Dineshan. So what the other thing, are you all confused with blood gases? Now have I made you confused? So is it easy, or what? I need your criticism about this lecture. Somebody.